Welcome back. I'm going to welcome our co-chair, Dr. Oberheim-Busch, to introduce our next session and speaker.
Thank you so much, Emily. I'm absolutely delighted to introduce Dr. Soonmee Shah, who is a neuroradiologist extraordinaire, and she's a colleague of mine. She's going to be talking about a window into the brain, Neuro-imaging 101. She's going to review imaging techniques most commonly used to monitor brain tumors. And like Dr. Lewis said earlier, your neuroradiologist may be a little bit behind the curtain because you don't necessarily interact with them, but they are such a vital part of everyone's care team. And Dr. Shah is incredibly talented. She's a professor in residence of radiology and neurological surgery at the University of California, San Francisco. She's the diagnostic radiology residency program director, and she's the radiology's vice chair of education. She focuses on the importance of validating the usefulness of MRIs as a tool for brain tumor diagnosis, monitoring, and identifying therapeutic endpoints. So thank you so much.
Thank you, Dr. Nancy Oberheim-Busch. I am so lucky to work with doctors like Dr. Oberheim-Busch, and it's really an honor to be here today, sharing some of my imaging experience at UCSF. I have nothing to disclose. And today's talk, I will be reviewing the overview of neuroimaging techniques that are used for diagnosis and monitoring of brain tumors. And I'm going to discuss some specific imaging techniques that are very helpful for on a day-to-day helping our patients with brain tumor and as well as neuro-oncologists like Dr. Oberheim-Busch. And I'm going to give you some specific clinical examples, how we use specific imaging tools to assess whether something is a tumor or a treatment effect. So there are three general topics that I will briefly introduce you to. I'm not going to dwell too much on the number one topic here because it's been really well presented today by our neuropathologists as well as neuro-oncologists. I will focus on neuroimaging techniques and also imaging of post-therapy imaging. So let's briefly talk about what are we calling molecular and genetic era. So I think most of you are very familiar that we are no longer just relying on histopathology of tumor tissues. And there are many of these higher, more advanced techniques to assess whether a tumor is a low grade, whether something is an oligodendroglioma or a tumor is astrocytoma. And I think this type of tremendous advance is going to march ahead and take us to the next level where these specific type of markers can actually serve as a treatment target. So I am super excited to watch and be part of this exciting molecular and genetic advances for neuro-oncology. How about neuroimaging techniques? So as my title says, this is sort of window into looking at my patient's brain. And it's a non-invasive technique. And yes, we do use CT sometimes in an emergency setting, but really the key is the MRI. Why? Because it does not use ionizing radiation and it gives me such great detail about what's inside. So every person with a brain tumor will get some type of imaging, and most of our patients will get MRI. And the question as a radiologist, I'm asking, number one, where is it? What is it doing to the neighboring normal brain? And are there more than one site of tumor? This is very important for our surgeons, as well as our radiation oncologists, as well as our neuro-oncologists. And even more important question that I always ask is when patient first comes to us, the critical question is, am I really looking at a tumor or is this a tumor mimic? So the neuroimaging in 2022 is largely divided into a structural or anatomically based MRI or physiologic based MRI and a hybrid imaging called PET-MR. And this is the standard protocol that we do at UCSF. And most of you are very familiar with gadolinium as the contrast agent. And we always try to give gadolinium because it really gives us a clear view of where the tumor, the enhancing tumor resides. So here's a patient with a glioblastoma, and you could see that pre-contrast before gadolinium versus after giving gadolinium, you could see distinctly where the boundaries of the enhancing tumor is. And this is very important for our surgeons to know. We also do physiologic MRI. And what do I mean by that? This is a diffusion-weighted imaging looking at cellularity of tumor. And these are perfusion imaging looking at the vascularity of tumor. This is a spectroscopy, a snapshot of a metabolic activity of a tumor. And we can also do functional MRI to see whether tumor is located close to an eloquent area. In this case, this is a human motor cortex. So if that area were to be damaged, patient will have a really significant hand and leg coordination problem. We also lay down these beautiful corticospinal tracts or other major tracts in the brain so that our surgeons can see where these very important tracts are in relation to the patient's brain tumor. So physiologic MRI that I'm going to just briefly introduce you, there are four main types. There's a susceptibility weighted imaging, diffusion weighted imaging, perfusion weighted imaging, and MR spectroscopy. So this is an example of a susceptibility weighted imaging. So what are we looking at here? We're looking at blood vessels, particularly venous veins, but also in clinical use for our brain tumor patients, we can look for blood, calcium, radiation injury, or any problem with vascular structures in the brain. And we can also assess vascular mass. So here's an example of how we use this susceptibility weighted imaging. This is a patient who conquered and survived medulloblastoma as a child, but received radiation, whole brain radiation. And these little black dots are micro bleeds or micro blood products, if you will. That is a very well known to associate with radiation therapy. Here's a patient with an inflammation of veins. It's not tumor at all. And you could see this nice stacked appearance of blood layering. This is not tumor, but this is an inflammation of blood vessel. And susceptibility weighted imaging tells us that this is probably going to not be a tumor. Here's a patient presenting with a vascular mass. This happens to be a cavernous malformation and not a tumor at all. So moving on, diffusion weighted imaging is very helpful because it tells us whether something is an acute infarct, if it's an abscess, demyelinating disease, or in tumor imaging, we look for tumor cellularity using this technique. Here are three different patients with three very different appearance of DWI. This is a patient with abscess in the brain. This is a patient with diffuse glioma, and this is a patient with demyelinating disease. And as you can see here, the diffusion weighted imaging looks somewhat similar, but this is a patient with acute stroke down in the cerebellum. And this is a patient with medulloblastoma showing very cellular solid mass. And without diffusion, we might not be able to exactly assess what type of tumor we're dealing with, but because of this technique, we are able to say that this is going to be a very cellular tumor, in this case, medulloblastoma, and that's exactly what that was. And there's been very nice study correlating diffusion-weighted MR imaging appearance with pathology, showing that these small, round, hypercellular tumors do in fact correlate very well with DWI. Perfusion is a technique that we look for vascularity. Here's a patient with hemangioblastoma, and you could see that the whole tumor is red hot. So surgeons, before going into surgery, they know that they're going to be dealing with a very vascular tumor, and that really helps them planning the surgery appropriately. MR spectroscopy is really a non-invasive metabolic imaging that we could glance at the brain and see whether something has an intact brain parenchyma or whether something is growing inside the brain. So we look at some of these markers and we come up with, this is actually a curve generated by MRI machine. And we could actually see, without even looking at anatomical imaging, we are able to say there's a high choline. So whatever this lesion is very proliferative. Here's lactate, suggestive of hypoxic process. Here's lipid, suggestive of necrotic process. And here's infectious process. So very helpful. And these are non-invasive. Each of these spectroscopy took less than 4 minutes to gain this much metabolic information. And diffuse gliomas, particularly the IDH mutant types, can accumulate 2-HG metabolites. So we can actually image this by using single voxel spectroscopy. And this is a technique. We know that this is going to be diffuse glioma, but if the patient does have this peak in the spectroscopy, we know that we are more likely to be dealing with IDH mutant tumor. So let me briefly finish up with pre and post therapy imaging. So preoperative setting, like I said, we're asking the question, is this really tumor? Where is it? And where would be the most malignant site? Are there additional sites of tumor? And is there a risk of hemorrhage? Post-therapy, we're asking the question, is this recurrent tumor or treatment effect? This is a very tough question because on imaging, they can look pretty similar. And we need to know what therapy and when patient got that therapy and what are the radiation fields and if patient has received bevacizumab or other imaging altering medication or immunotherapy or others. So there's a lot of complexity here, but the neuro-oncologic imaging pre and post therapy remains pretty much similar. And this is the question that we ask. Here's a patient came to us with a diagnosis, presumptive diagnosis of GBM, but once we add DWI and ADC, this does not look like GBM. And we told the surgeons, and this is in fact not tumor at all. This is an abscess full of pus. How about this one? This patient does have glioblastoma, but looking at this FLAIR technique, we let our radiation oncologist know that there's additional site of tumor in addition to the dominant one, so that radiation oncologist to make sure that area gets radiated. And here's another example of looking down into the inferior aspect of the brain to know that in addition to this tumor in the right thalamus, patient also has additional tumor down in the posterior fossa or cerebellum that really needs to be addressed during radiation therapy. Are there metastases? This patient was thought to have brain metastasis from systemic cancer, but we added a couple of spectroscopy and noted that there's no high choline, which is the marker of proliferation, and there was lactate peak, so a very limited biopsy was done, and this was not metastasis cancer at all. This was a proven demyelinating lesions. How about this one? Is this tumor? This is a patient that we've been following since 2003, and over 17 years, this lesion doubled. So finally, we sent the patient for 2-hydroxyglutarate spectroscopy, and lo and behold, this particular lesion had a distinct expression of 2-HG, which is a surrogate marker of IDH mutant diffuse glioma. And in fact, patient was sent to surgery at UCSF, and this is a proven oligodendroglioma IDH mutant. Where to biopsy can be important too. By using perfusion imaging, we can guide our surgeons to take a sample where there's a lot of vascularity. And this can be very helpful in terms of guiding our neurosurgical precision biopsy. And functional MRI can also help with getting our surgeons out of trouble so that they do not injure these eloquent areas of the brain. And I think Dr. Mehta already beautifully talked about radiation therapy. Without imaging, planning for radiation therapy will not be as precise. It's either CT or MR based, and many new techniques are coming out, and almost all of these are sophisticated 3D rendering image based. So imaging is a critical part of your radiation therapy planning because of this advantage of providing amazing 3D imaging. And then I'll just finally finish off with the complexity of what we're dealing with after therapy. Surgery and many other different techniques could be done, and we don't know exactly what we are dealing with when we're looking at imaging after patient had therapy and surgery. So we have to make sure something like this. You could see that as SWI imaging of this mass shows all these microhemorrhages. So in this setting, this is most likely going to be radiation necrosis. And indeed, that's what that was, and not a tumor recurrence. Here's two different patients. This is the Medulloblastoma Survival, and this patient had a different type of tumor, and both shows radiation-associated therapy complication. But again, these are commonly seen after whole brain radiotherapy. Here's a patient who got much worse after radiation therapy, but our neuro-oncologist gave the patient steroids and kind of calmed things down. And 3 months later, you could see that immediately after it got really worse after radiation, but 3 months later, it gets better. And this is what's been called in the literature pseudo-progression. Is this recurrence or not? This is the last case. If you look at this, it's a gyral form, very specific pattern of enhancement. And we know that this is a now very well described entity called SMART syndrome, stroke-like migraine attacks after radiation therapy. So this is not tumor at all. And imaging can be very helpful here. So with that, I'll conclude that neuroimaging is essential for treatment of patients with brain tumor, both at diagnosis and monitoring. And there are more advances in imaging technique coming our way, so look out for that. And imaging has to keep pace with this amazing molecular genetics and tailored therapy that are coming to our doorstep to improve the outcome for patients with brain tumor. So with that, I thank you for your attention, and I will take any questions. And again, thank you again.
All right, thank you so much for that wonderful presentation. As a reminder, if you have a question that you'd like to ask, please type it into the right-hand side of your screen under the Q&A section. Just hit the Ask a Question button, type and submit, and we'll answer as many questions as time allows. Okay, so one of the first questions we have here is asking about the smallest size tumor that an MRI can pick up. Do you know what the smallest size mass is that an MRI is able to show?
That's a good question. We could see probably 1 millimeter lesion. Now, 1 millimeter lesion on MRI could be about 100 different things. So just because we can see it does not mean we know what it is. And as a matter of fact, as we age, we develop what's called a microvascular changes that are showing up as a small 1 to 3 millimeter dots that may not be tumor at all. So the spatial resolution of MRI could be as low as 1 millimeter, but there are many, many other things that could be representing. So you have to be careful that MRI, while it's super sensitive, it's not specific.
Thank you so much for sharing that. Another question we have here is asking, is contrast necessary for each and every MRI to get a clear image? Or are there ever any instances where contrast is not necessary?
So that's really a great question. So when we have pregnant patients coming in with a brain tumor, we never give gadolinium unless we absolutely have to. And let's say if patient had a lower grade diffuse glioma and the tumor was not enhancing from the get-go, I guess we could make a case that, FLAIR imaging or DWI could be used. But for patients with a higher grade tumor, such as glioblastomas or metastatic cancer, we really need gadolinium to see these small tumors. And we don't want to miss early recurrence by not giving gadolinium. So in exceptional cases, we will not give gadolinium. But I would also say that there's been literature about gadolinium depositing in the brain, but there's been no published reports that I'm aware of showing that gadolinium in the brain has any neurocognitive effect. So we'll see how it goes. But gadolinium's been around for about 3 decades now, actually a little bit more. And I am personally not aware of any neurocognitive risk that gadolinium poses. So I'll just put that out there.
Thank you so much for sharing your insight on that. Another question we have here is asking about how imaging can be utilized to distinguish between residual tumor that may be left after surgery versus swelling in the brain. How does that look different?
That's a super great question. So short answer is we cannot tell, because edema as well as infiltrating glioma can look just the same. Now, the short answer to that is if what looked like an edema disappears in a month, then we know, go back, oh, that was edema. But if it persists a month later or 2 months later, then we know that that's either going to be some residual tumor but don't forget, there's an entity called gliosis, meaning it's a scarred tissue. They can look the same. And that's probably why my job, everybody's job is very challenging these days, but I really have to pay attention to know that what kind of therapy was given to interpret whether something is a therapy related versus truly tumor related, because they can look identical on MRI imaging.
Thank you for sharing that. To add to that, what about necrosis? So active or residual tumor versus necrosis. Is it very similar to edema where wait and watch is what you would recommend, or is there anything else that can be done to determine the difference between the two?
Yeah, that's a great question too. So we actually use susceptibility weighted imaging that I showed you that shows these little black dots everywhere. So that's how I know radiation has been there. So if there's punctate of dots everywhere and there is what looks like a necrotic lesion that's growing, I have a good sense that most likely this is going to be radiation-associated injury. So we use SWI or susceptibility weighted imaging quite a bit, but we also use spectroscopy, those nice curves that I showed. Those are 3 minutes each. And if it shows really high choline, which is a marker for tumor proliferation, then we will be more suspicious that this might be tumor. But if it shows lactate or lipid metabolites, those are more associated with radiation necrosis. So we do have some tools. These are not 100%. We also use perfusion. Growing tumor has to have blood supply. So if red hot dot appears in what looks to be a necrotic, adjacent to necrotic tumor, we are suspicious that that might be a recurrent tumor. So yes, we do have some techniques that we use every day, but these are not 100% proven tools. So time sometimes is our best guidance to determine.
Thank you so much. I think we have time for maybe a couple more questions. So this question here is asking if exposure to repeated MRIs can lead to a higher risk of tumor reoccurrence or tumor growth.
No. So CT literature, so computed tomography is the one that's now been well established that if you get a lot of CT, there's a cumulative radiation dose associated with that. So in children, we very rarely do CTs. But in terms of MRI, MRI does not use ionizing radiation. It's a magnetic resonance, and I am not aware of a single literature that states or proven or studied that MRI causes a tumor, or in the long run or short run for that matter, because it's not ionizing radiation.
Thank you so much. We'll take one last question. This question here is asking, can PET scans pick up small brain lesions, or are MRIs kind of the standard, the best tool to use?
That's an excellent question as well. PET is a super powerful technique using specific metabolic target. Now, caveat is that PET imaging, the resolution is quite low. So really, we need at least 1 centimeter lesion to be picked up by PET imaging. Now, if anyone's going to get PET imaging, we recommend it's either PET CT or PET MR, so that we can actually see the higher resolution anatomical imaging superimposed with so-called the hotspots of PET imaging. So PET definitely has a value, and it could be amazingly helpful, but it really has to be taken in the context of what anatomical location are we talking about. So for example, sometimes normal pituitary gland can look hot as can be. That doesn't mean there's cancer there. So we have to know which region is the PET picking up this hypermetabolic activity. Sometimes if you're talking, your throat can be very, very hot on PET as well, or chewing something. So again, these technology has to be really put in the context of what are some of its inherent limitations. So PET, while powerful as a metabolic agent, it's not as good as a highly sensitive, spatially high resolution imaging. So that hybrid imaging is really the key to get the most amount of information from PET information.
Thank you so much, Dr. Cha, for sharing your insight and expertise. That is all the time that we have for this session. I'm going to go ahead and turn it back to Emily.
Thank you. And I would like to thank Emily and Mindy, who are super helpful. I really cannot thank them enough. Thank you.